On this episode of the ASC Podcast with John Goehle, we discuss the latest news, discuss how to prepare for your annual board meetings, review annual mandatory education requirements, and provide a reminder about periodic hospital reporting. In our focus segment, we discuss some common citations for AAAHC and ACHC.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 211 of the ASC Podcast with John Goehle for January 14th, 2024, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
I noticed that you hesitated when you mentioned the date that of this recording. This is what we refer to as take two.
Yes.
We recorded this indeed on January 14th originally, and
the whole thing.
Somebody forgot to hit the button for your microphone. Mm-hmm. I think it's Rosie, the dog, but unfortunately that appears to have been my mistake, and the recording was kind of one-sided. So we have to re-record it. Hopefully it'll be as good as that initial one was. But Sue, welcome back.
Thank you.
We missed you here. Of course, we had to bring in a guest co-host. Mm-hmm. Katie Pearson, who did a good job of filling in, and we really appreciated that she could help out. Sue's been out on family medical leave.
Paid family leave. Just helping my daughter with her daughter. She had a new baby and just had a little longer recovery, so taking some time to help her out with that and spend some time in the hospital with her when I needed.
So we've been kind of busy in the house lately, but last week we did have a very successful credentialing conference, the Credentialing, Privileging, and Peer Review Conference, which was a day and a half conference we put on. It was our second most successful conference ever, and for those that were not able to attend it, the on-demand version of it should be available in about 2 to 3 weeks. We are running a little bit behind on that because the person who does a lot of that editing, of course, is the young lady who had a baby just before Christmas. And Sue, during the conference, we had some wonderful interaction with all of the attendees. It was probably, in my view, one of the most interesting conferences we had. A lot of questions that were very relevant, that really, I think, made it relevant for the people that attended. But one of the discussion items that came up is the possibility of doing a quality improvement and risk management conference. So we are already working on that. Hopefully we'll have it. We actually have a target date of April 5th, but no promises on that. We'll see if we can pull that together. And that will be one of our micro conferences similar to this and the conferences we did in November, which will be a full day conference focused on a particular topic, in this case, quality assurance, performance improvement, and risk management. And we also had an interesting conversation about an anesthesia conference. Now, I'm not sure this would be a full-day conference, but there's so many issues coming up with anesthesia, not only the anesthesia crisis, but what organizations are doing to try to deal with the difficulty in finding anesthesia providers. I was on a meeting earlier today where one of my colleagues was telling me that a place in outside of Philadelphia, this is anecdotal, but apparently a place outside of Philadelphia had to shut down operations because they were unable to find anesthesia providers.
Not surprising, though, with the shortage.
Right.
It's getting really difficult.
Well, and the reason it came up during the credentialing conference is because there are a number of things you have to do when you're credentialing anesthesia providers. For example, with a CRNA, usually that involves supervision by the physician provider, and that has to be included in the anesthesia credentialing and privileging. So a lot of issues on that. We're still working on that. Not sure where that's going to head. We do have 2 upcoming boot camps, the Administrators Boot Camp. The live virtual conference portion of that will be January 23rd to the 26th, so that's next week. And this will be starting our 4th year of doing this conference. I can't believe we've been doing it 4 years. Our boot camps now have over 250 graduates, by far the most graduates from any program of its type. And we do have our Business Office Manager Conference coming up. It's our second one. We did one in August. We decided to move it to March just to make it a little more available to people. It turns out I don't think that August was the best month to hold that type of a conference. And that's going to be March 12th through the 15th. And we're doing that in conjunction with Coding Compliance Management and our dear friend Christina Benton. Sue, I think we have some recent news we have to get caught up on.
Yes, we do. So there was an article in OR Manager on December 18th about the difference in colonoscopy fees between hospitals and ASCs. This data was gathered from the federal rule requiring transparency and coverage, which requires insurers to publish in-network rates for covered services. The hospital fees were approximately 55% higher than the ASC rates. So the average hospital bill for facility fees for colonoscopies was $1,530. For colonoscopies with biopsy, hospital facility fees were $1,760 and $1,761 for colonoscopy with removal of polyps. The same fees at ASCs were $989, $1,034 and $1,030 respectively, or between 54 and 61% lower. So I know that we always know we're a good value, but that just really is a huge difference.
Yeah, absolutely. And again, this is from an OR Manager article. We'll provide a link to it. But it is yet more evidence of the importance of shifting procedures into the ambulatory surgery setting, particularly things like colonoscopies and endoscopies, which are, pretty commonplace now in an ambulatory surgery setting. And Sue, I saw an article in Becker's ASC about the Stark Law. We haven't really talked about the Stark Law in a while, and this article talked about where it stands and where it's headed. And we'll provide a link again to the article. But just a couple takeaways that I had from the article. And before we get into it, I do want to remind you that these are legal issues, and we need to make sure that you have a good healthcare attorney on retainer to deal with any of these issues that might impact your organization. Let's start with a reminder of what the Stark Law is. It's a law which prohibits physicians from making referrals to some Medicare-certified healthcare facilities if the physician or certain family members are owners or have some other type of financial relationship to the center, such as an employment arrangement. Please read the article, but I thought I'd note a couple takeaways, particularly as the new year begins. Perhaps something to do just to check on within your own organization. The Stark Law is what we call a strict liability statute, meaning that you can be found in violation of the law even if you didn't intend to violate the law. This is one of those classic ignorance of the law does not excuse you from following the law situations. Now, the National Law Review noted that violators could potentially face a $15,000 fine for each violation of the law, plus additional civil penalties of up to $100,000. We want to encourage administrators to make sure their owners are aware of the potential penalties for these violations, and of course make sure that a lawyer looks into all of your partnership, the LLC, and other agreements involving your owners and other providers. CMS is getting very aggressive about enforcement, and this is to combat healthcare fraud. It's one of the administration's highest priorities right now in the area of fraud. Some areas of recent focus during these investigations have especially been compensation arrangements. For example, medical director or other compensation arrangements with owners and providers. They want to make sure that they are not based on volume or referrals. So you need to make sure those are arm's length arrangements, financial arrangements, and again, make sure a lawyer is involved in that.
And recently, the FDA posted a voluntary recall from Leiters Health, recalling IV bags of vancomycin, phenylephrine, and fentanyl due to potential for superpotency, as they could contain twice the labeled amount of the drug. There may have been an issue with the equipment used to autofill the IV bags, so they may not have moved along when they should have and gotten that second dose put in there.
Double the dose, probably.
Yes.
Yeah.
Yep. There is much more information on the FDA website. We're going to put a link in the show notes that really detail the risks that you would be facing and listing the specific lot numbers so you can check to see if you have any of those. And an article in Nursejournal from November discussed CRNA use and supervision. They noted that more than 80% of anesthesia providers in rural communities are CRNAs, and many rural hospitals provide CRNA-only anesthesia care. As of the end of 2022, 23 states did not allow CRNAs to practice independently, or they implemented supervision requirements that were just too complicated or difficult to follow with the shortage of providers. Outpatient care centers make up 23% of CRNA's employment, while only 3% of anesthesiologists work in outpatient care centers.
So this is an area that we really want to keep a very close eye on right now. I know there's a lot of proposals for changes in the regulations in various states, those states that do not allow independent practice of CRNAs. So we'll have to keep a very close eye on that, as this could be a potential solution to our anesthesia shortage. Though, to be truthful, there's a shortage of CRNAs also, so it will only help us, but it's not necessarily a solution to our total problem.
It's not necessarily the answer. And according to Becker's ASC review from December 8th, Florida, Colorado, and Delaware are working to remove restrictions on CRNA's independent practice. And U.S. Representatives Sam Graves from Missouri and Jared Huffman from California have reintroduced the Save America's Rural Hospitals Act, which would expand the scope of practice for certified registered nurse anesthetists, allowing them to work without physician supervision. Now, the AMA is opposing these changes, citing the shorter training periods and lack of residency requirements in a CRNA's education. So they're concerned about patient safety. So we'll put a link to both of these articles.
So this is an evolving issue, and again, one of those reasons that we really are considering a conference to discuss this at a national level.
We really need, I think, some good studies and just find out whether patient safety is affected, if there's certain settings that are better for CRNAs. Just really get some good guidance on this.
I agree. So it is the beginning of the year, and I thought that we might want to talk about some of those things we do at the beginning of each year, or that are usually done on an annual basis. Let's start with that CMS requirement that you send a letter to the hospital, your local hospital, every 2 years. Talking about your existence, your presence. This is a change that was made in the latter part of the Trump administration when they were trying to reduce regulations and, in effect, actually created another regulation or regulatory requirement. And the regulation states that the ASC must periodically provide the local hospital with written notice of its operations and patient population served. And in the interpretive guidelines, this was what was stated. You need to provide information concerning the ASC's operations. For example, this would include the ASC's name, address, hours of operation, administrator's name, and contact information for any follow-up questions, and the patient population served by the ASC, which would include but is not limited to your surgical specialties and whether the ASC sees adults and or pediatric patients. And they noted that the written notice may be provided to the local hospital electronically or through the mail, and the ASC should maintain copies of these notices to demonstrate that they are providing such notices periodically as required by the regulations. So if you haven't sent that out in the last 2 years, it's time to draft that letter and send it off. And truthfully, I would imagine most of these hospitals, given how large most hospitals are, probably won't even notice the email or the letter, but you do want to keep a copy of it just to prove that you did what the regulation requires. Let's also talk about what goes on at our annual meetings, and just a couple guidelines for those meetings. First of all, you want to appoint your officers for the year, the officers of the board. You want to make sure you appoint all of your committee members for the next year. And then there's various positions within your organization that surveyors are looking for. We want to know that the governing body has delegated responsibility of various positions. Now, the regulations don't necessarily require you to do this on an annual basis, but it is often difficult for you to go back to the board meeting where you made these appointments in the past. And this is particularly important just so that you know when there's turnover, and unfortunately there's been a lot of turnover lately, but when you have turnover, you know exactly what positions that individual who was left was appointed to, especially, Sue, since there's an awful lot of crossover here. We're going to list, I don't know, I didn't put a number here, but a good 10 or 12, maybe 15 positions, and in some smaller centers, there's only 2 or 3 people that make up those positions. Let's just go down the list. And again, some of these positions might have slightly different titles. We'll just give you the most common titles. So the first one is administrator, then clinical manager, the RN, often a director of nursing is the title, the medical director. And if this is an anesthesiologist, you're going to have somebody that's also going to be like the director of surgical services or medical services. You're going to have an anesthesia director, a business office manager, a director of quality improvement and risk management, an infection control coordinator, an education coordinator, a laboratory director, a pharmacy director, a radiology director, if that's applicable, a safety officer, a risk manager, compliance officer, a privacy and security officer, a medical director, a medical records director, or often it's called a health information systems director, a tissue bank compliance officer, if that's applicable, and a laser safety officer, if that's applicable.
And as you mentioned, one person could do quite a few of these roles, and especially in the smaller centers, you'll see that. But be sure that, like say it's your director of nursing, that is also your QAPI coordinator. Make sure that they have job descriptions for all of those
for all those positions.
Roles.
That's a very good point, right? Also, on an annual basis, you got to do reviews of various programs. Like you have to review all of your policies and procedures and all of those plans, like infection control, risk management, safety, et cetera. You're going to have to, big recommendation. We had a huge conversation about the medical staff bylaws during the credentialing conference, since the medical staff bylaws have a big impact on the way you do credentialing, privileging, and peer review. So do review your medical staff bylaws. One thing we realized during we've realized it for a while, is that people often don't look back to these bylaws, which are often written at the very beginning of the operation. Yeah. So take a very close eye out these bylaws, review to make sure that they match up with what your actual practice is. For example, I just read one this afternoon, Sue, where it talked about a credentialing committee, and there is no credentialing committee for this organization. So be very, very careful, and also follow the rules with regard to revising the medical staff bylaws, because they often are not as easy to change as the policies are. Also want to talk a little bit about annual mandatory staff training. Remember, on an annual basis, you do need to do staff training, mandatory training. There's a lot of different areas you have to cover. And I've noticed that a lot of centers are starting to use these online training programs. I'm not going to talk about what's provided in those programs. I want to talk specifically about those things that those online programs cannot provide you, which are facility-specific, organization-specific issues. For example, the infection control program, you can't use one of these national organizations unless you upload your own training materials for your infection control program. Fire safety, the same thing. Your organization is going to have different types of fire detection systems, fire suppression systems, different exit pathways. All of those things have to be in an educational program that you have designed specifically for your center. Same thing with emergency preparedness. Of course, your center might be very different than a center in a different part of the country. You have to talk about how you would transfer a patient to the hospital, the process. You also talk about Code Blue, malignant hypothermia, and then you have to review the various quality improvement, peer review, programs that everybody needs to know about. And another important thing, don't forget that your providers need this education also. So you need to demonstrate in your credentialing file that all of the people that have been credentialed to provide procedures at your center have had that same education program that's specific, for things that are specific to your organization. So as we enter the new year, I thought we would take a look at some of the common citations. And recently, AAAHC and ACHC have issued some reports that showed some of those common citations. So we're going to take a short break, and when we come back, we'll review some of the common citations from various accreditation organizations. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our administrator boot camp and the director of nursing boot camp, and in 2023, the business office manager boot camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central patron program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. So periodically, we like to discuss the various citations that organizations are likely to run into during surveys. And fortunately for us, the AAAHC issues an annual report called the AAAHC Quality Roadmap. We'll provide a link in our show notes for you to be able to download it. It is free. You just have to provide your email address and information, but it's free, both organizations that are already accredited by AAAHC and those that are looking to become accredited. And I really recommend you look at it. It's an excellent document, really one of the best summaries that are available for all the accreditation organizations on the activities. And for the report that was just issued, it represents 1,749 surveys from organizations, including ambulatory surgery centers, OBSs, and primary care settings. We, of course, are really only going to talk about those things that apply to ambulatory surgery centers. And we should note, we're not going to talk about all of the findings, just the ones that were really, I think, above 50% of the centers, right, or very close to that.
Yep, and we thought probably the most useful way of doing it is we've got the surveyor findings and their hints for compliance.
Right, and as well as our own observations here. So,
so for emergency preparedness and drills is the first section. Some of the findings are the drills were not scenario-based, which we see that a lot. Drills are not completed on a quarterly basis, and drills were not consistently evaluated.
And I find this in mock surveys, too, that often organizations just, pull a fire alarm, or they don't even pull a fire alarm. Everybody exits the building, and then, that's their drill. Well, all drills have to be scenario-based. You have to create a scenario, act out that scenario, document that scenario, and make sure that you do one every quarter. And, of course, we're talking about both fire drills and emergency drills. And AAAHC provided a couple compliance hints. They recommended that you create a template form or a checklist for drills that include who is participating, a description of the scenario, and an evaluation of the drill and steps to improve. And it's important to note that surveyors expect to see an evaluation. We don't really want to see you saying, oh, everything went well, because that's not the purpose of a drill. The purpose of a drill is to push the limits, to be able to identify things that might not actually come up during the average fire, so that when people actually do encounter a real fire, they're really prepared for it.
And I think, as you said, about pushing a little bit more. So if you're finding you're having a difficult time finding anything that went wrong, or, really keeping people engaged, then switch it up. Make it a more difficult thing. Make it a fire that happened, during a procedure. Have it happen in a different room, or when, just throw some little twists in there that challenge people so that you can really learn something from these.
They also recommend that you have an impartial party view emergency drills while they are being performed and conduct the evaluation for you. And Sue, I do want to kind of put a pitch in here. Those that are members of our patron program and members of our patron program and our premium access programs, both of which are available on ASC-Central.com, have access to this large database of fire drill scenarios and what we call kits. So they provide you a Microsoft Word document that you can use to fill in to document that drill, as well as a lot of different scenarios, including, I believe, a scenario for World War III and the zombie apocalypse. So
I think our director of operations loves to get creative with these things.
Yeah, I'm not sure about the zombie apocalypse, but World War III, given everything that's going on right now, that might not be a bad one to prepare for. And then the second highest area was in credentialing, privileging, and peer review, which, of course, was the whole reason that we did the conference last week on that. So those of you that attended that conference or intend to do it on demand might find a lot of information to comply with these findings.
So they found that there were often missing reappointment supporting documentation, or contracted providers did not have credentialing or privileging documentation. Files contained expired documents. Privileges often were not explicit to date-specific time frame.
In other words, the specific dates from, not just the months, but the specific dates, and making sure that they don't go over the time frame that had been established in your policies.
And allied health professionals often were not privileged by the governing body.
And they noted that there were situations in which privileges were approved for the supervision of an allied health provider. However, the organization doesn't use allied health providers. And they also noted that that in a number of circumstances, privileges were approved for procedures that were actually not even on the approved procedure list or even performed at the center. So a good note here is just make sure that every situation in which you're granting privileges are a situation that actually exists in your organization.
And then sometimes the privileges were missing for procedures that are being performed. So if you're ever adding things or even just changing, using a different type of laser or something like that, different levels of sedation, you have to make sure you add that. No peer references were provided on initial application. No formal ongoing process for peer review was established. And no privileges for supervision of anesthesia services sometimes were found.
So those were all things that we talked quite a bit during our conference, and definitely peer references was a big topic of discussion. And also whether you really need them for reaccreditation, which generally, unless your policy states it or your accreditation organization requires it, generally peer references are not required because you are required to do peer review. And AAAHC made gave some hints for compliance. They wanted to suggest that you keep up to date with time-sensitive information, for example, a state license, DEA registration, medical liability coverage, et cetera. They want to make sure that you include contract and allied health providers in the credentialing process. I should note that it doesn't mention it here, but also making sure that your residents who provide direct patient care are also privileged in your organization, go through a credentialing process, albeit a shortened one. They also suggest that you keep explicit written procedures for requests and approvals to follow those consistently. This is when an outside organization requests information from you about the privileges of one of your providers.
And, of course, include a specific time period for which the privileges are granted and documentation of initial privileging and reappointments. So that should be in your board minutes. This documentation should be date-specific and must also include which privileges are requested and which privileges are granted.
I can't tell you how many times I see this as a violation, either during a mock survey or when I'm actually doing a survey. And you want to ensure records include the documentation of specific privileges. For example, levels of anesthesia, the type of ultrasound and laser equipment that you're going to use, and, of course, supervision. Mm-hmm.
So it can't just say, you're going to be doing arthroscopies or whatever.
Correct. And, of course, something that I found interesting here is communicate to staff the privileges granted to the providers. Make sure that all of your staff know this, and particularly the staff in the operating room, and the staff that are involved in scheduling. You don't want to schedule a case or be in the middle of a case when you realize that provider didn't have privileges to do that.
And ensure the peer review process is an ongoing review of all providers and shouldn't be limited just to incident-based review.
And you want to expand the peer review criteria to include review of clinical records as well as ongoing clinical care, and incorporate other items such as infections, hospital transfers, adverse event rates, patient satisfaction survey results, and compliance with medical staff rules and regulations, as well as clinically based outcomes criteria decided by the providers themselves as part of that peer review process. So we talked about that a lot during our conference, but as we discussed, there are quite a number of situations in which these are issues for during surveys.
And under medication reconciliation, some of the findings were that it was not being performed or not consistently performing medication reconciliation. No notation upon discharge whether or not to continue the medications. Medication lists were sometimes not accurate or were not complete. And the medication lists sometimes contained misspellings or the wrong dosages, or didn't note the times that the medications are to be taken. And multiple medication sheets were found sometimes, but the reconciliation process was not identified.
And here were some compliance hints. They suggested that you determine one consistent method for documenting medications and incorporate into your policies and procedures and staff training. And if you have an EHR, make documentation of medication reconciliation a required field in the EHR system. And if you're still using paper documentation, use one consistent form for medication reconciliation that the patient reviews and receives a copy at discharge. And of course, lastly, a big trend here is make sure you train your staff on medication reconciliation requirements.
And next was allergy documentation, which really was a lot like the medication reconciliation. They just said often it wasn't accurately documented. They may be missing the sensitivity information or missing reactions. It may not have been updated consistently, or it was documented in multiple areas, which is going to increase your risk of errors. So they just want you to make sure you're consistent with where you put those allergies so everybody can find it. If you have an EHR, make sure that the reactions and the sensitivities are required fields. With paper documentation, use one consistent form. Make sure it's always in that same place so people know right where to find it. And, of course, train your staff on allergy documentation requirements.
And moving on to pharmaceutical safety, other findings were that there was no list of high alert medications, no process to identify high alert medications, that confused drug names were not labeled, the drugs were not labeled, and there was no monitoring activities for monitoring high alert medications or medications with confused drug names. So usually we suggest working with a pharmacy consultant that can help you identify these drugs and post signs. And they do recommend that you maintain a list of, well, not recommend, they require you to maintain a list of high alert medications used in the facility and keep them near all of the dispensing locations. And you want to segregate and label high alert medications for easy identification. And, of course, you want to train your staff to minimize medication errors by alerting them to high alert medication and confused drug names used in your facility.
And next was infection prevention and control program. Some of the findings were no formal infection control risk assessment was documented. No active surveillance for hand hygiene or safe injection practices was present. That surprises me. I feel like that's kind of
pretty standard.
Everybody sort of does that. The rubber septum of the medication vials and IV hub were not always cleaned with alcohol prior to needle insertion. Hand hygiene was not consistently performed per policy. Open vials were not labeled. The organization does not have the manufacturer's instructions for use available to reference, and that's a big one. You always have to have that
for everything
available
in your organization.
For
all your supplies and equipment.
Yep. No national guidelines reference for sterilization procedures. Manufacturer's instructions for use were not followed for disinfecting agents. No policy was present for cleaning, disinfection, or sterilization. Biological testing was not completed per national guidelines. Hinged instruments were not sterilized in the open position.
And AAAHC provided some hints for compliance. Of course, you want to implement an active infection control risk assessment and surveillance process. So it's not just enough to, we have a problem making sure that you even do the risk assessments, quite frankly. But many of the risk assessments that I've reviewed over the last couple years haven't had any conclusions. So somebody just filled out the the columns and came up with a conclusion but didn't do anything to determine what changes need to be made to your infection control program. So it's important that you not only do an annual risk assessment, infection control risk assessment, but that you also develop your infection control program and goals and objectives for the next year based upon that. And of course, they suggested that you utilize the standard CDC, WHO, and APIC, and other resources for hand hygiene guidance, and also make sure that you use IPC training and competency testing upon hire and at least annually thereafter, or when there's an identified need. And it's also important to make sure that you're looking into safe injection practices as part of your surveillance activities, using different staff. This is true both for hand hygiene and safe injection practices, to have different observers do this on a regular basis within your organization.
And provide up-to-date manufacturer's instructions for use on all equipment and instruments for easy staff retrieval. And they had mentioned that above, too, that's also when you want to do more training because, sometimes you just change one little thing, but somebody has to really read those instructions and make sure that the timing or whatever else hasn't changed.
Yeah, and that's the reason we do surveillance activities. If the surveillance activities indicate a low compliance, then that's an issue. And I guess this is a good point to mention. So often we see the surveillance activity worksheets coming back saying 100% compliance. And that's really not very accurate in many cases. And especially if a surveyor comes in, like if you're saying you'd have 100% compliance with hand hygiene, I got to tell you, as a surveyor, I'm going to be looking very closely at your operations. And the minute I see one situation, and I'll tell you, often I see a lot of situations in that scenario, then I'm not going to believe that really that any real surveillance was going on.
You either have, need somebody a little bit tougher. Sometimes people just really feel bad and they don't want to write somebody up, but they don't have to put their name. They just have to do that. Or you have somebody doing it that is always the same person. Maybe they're in leadership, and whenever they come near, everybody kind of steps to it and does the right thing. But you really want to make sure you're getting an accurate picture of that.
And, of course, you want to train your staff on the National Sterilization Guidelines, and you want to observe and enforce safe injection practice guidelines, especially with multi-dose vial storage, administration, and labeling. That's been a huge issue lately. Remember, multi-dose vials have to be drawn up outside of the patient care area. And I think we've talked about that on previous episodes quite a bit. You want to review the AAAHC Safe Injections Practices Toolkit. AAAHC has these wonderful toolkits that are available to all organizations that are accredited, and you really need to look at that. Now, we should note, as we get into the Accreditation Commission for Healthcare, the ACHC findings, that we're not going to duplicate those things. There were quite a bit of crossover, of course, as you can imagine. We thought we would mention some of those findings or survey issues that ACHC brought out that were not identified in AAAHC.
And, of course, with both of these areas, we're just summarizing. So, we're not claiming.
We're not going through all the findings.
Showing every single thing. Okay, so for personnel records, 41% of the centers were cited for something in personnel records. Some of those findings were individual files were lacking evidence of licensure verification for licensed personnel, evidence of an initial orientation and of competency validation during orientation, an annual appraisal, annual competencies or required annual training, evidence of initial required training, and position description. And I know, as I mentioned earlier, make sure that if one person holds several positions, that they have signed job descriptions for all of those.
Right. And I did note that personnel files of contract personnel also have to include evidence of training and or periodic evaluation, which we refer to as peer review here. So, again, these are talking about actual employees of the organization, but moving on to contract employees or medical staff, as they refer to it. 70% of the files, this is a very high number, had issues with regard to the credentialing files. And they noted that credential files reviewed contained a single recommendation and where multiple recommendations are required. So important to follow that if you are ACHC. And I should note that whatever your policy is, even if you're not ACHC, make sure you're following your policy and have a minimum number of peer references for every applicant. And some individuals had been credentialed at another facility within the corporation, but the files did not include documentation specific to that center. So I think what they're talking about here is larger organizations that didn't maintain their credential files on site. And they also noted some situations where individual files lacked a current unexpired state license where the DEA registration card was not current, where there was no evidence of malpractice insurance, of current malpractice insurance, where there was no evidence of a criminal background check. Now, this is a requirement of ACHC, but your policy might also require that. And again, if your policies require it, you need to do it. Evidence of current board certification, if it is required. National Practitioner Data Bank and OIG queries. Evidence of current competence. And assigned attestation to complying with the bylaws, as well as a request to be granted specific privileges, and a letter signed by the governing body, including the decision, the scope of privileges granted, and the duration. So some of the similarities between the two. I was very surprised at the percentage. AAAHC didn't provide a percentage number for all of their findings, so I wouldn't be a bit surprised if it was the same. But again, that's the whole reason that we did that conference the last couple of days. Yeah. So really recommend that you listen to that, as well as some of our free podcasts where we talk about credentialing.
So some of their tips, they just reminded you to review the relevant ASC policies annually to ensure that all required items are listed, and use this to develop a checklist of all items required for privileges to be granted. Identify contracts for credential verification if used, and for background checks, because that's what they do, require background checks at ACHC. And don't advance the request to the governing body until all of the required elements are available for review. And add calendar expiration dates for medical staff licenses, privileges, et cetera, to kind of, little ticklers to remind you when things are going to expire. And I think what they were talking about above, if the medical staff is shared with a partner or otherwise affiliated organization, privileges must specifically identify all locations for which the privileges are approved.
And I do want to go back to one item. It does say do not advance requests to the governing body. That's a very important thing to note, is that your credentialing process has to be complete before you grant privileges to all those providers, and it doesn't matter what your accreditation organization is. That is obviously a requirement. And moving on to quality assessment and performance improvement, they found that 38% of the centers had issues in this area. And examples of the issues that they found is the organization does not have a written quality improvement plan containing any of the required elements. That's kind of scary, isn't it? And or situations in which it doesn't necessarily follow that plan and doesn't track and have documentation that those indicators that are included in a quality improvement plan are actually being tracked and trended. And then they indicated that sometimes staff interviewed did not have knowledge regarding quality improvement activities. And I think, Sue, this could also be said for medical staff members. If you're not doing training, as we talked about in our first segment, of your medical staff, and a surveyor asks them, about the quality improvement program, if they indicate they are not involved in it or not aware of it, that would be a failure of your training. And one of the requirements of ACHC is that you do have to have an annual report of the quality improvement program, which is not necessarily required for all other organizations, though many centers do that. But you do have to have an annual QAPI plan. And ACHC noted that often these plans lack the staff responsibilities, a method of data collection, and the frequency of that data collection. So something you definitely need to keep an eye on.
And I do want to just read their comment on deficiencies, because I think it's a good summary. The quality improvement is a primary goal of accreditation. Compliance is assessed through staff interviews, like you mentioned. So you have to make sure your staff really knows what you're doing to improve things, and through document review. Most citations resulted from a lack of a QAPI program or failure to identify performance indicators for all areas of the ASC, including contracted services. And then they recommended at the end here, rather than trying to begin by defining quality measures for each area, start by auditing the data you're currently collecting and categorize it by service, and make sure all areas of the ASC are included, and then implement your change incrementally. Simultaneous changes will make it difficult to identify the driver of improvement.
Yeah, I think that's a good advice everywhere in leadership is, don't try to do everything all at once. Of course, it's hard to say, or it's easy to say that when we're sitting here, but when you've got a survey coming up, of course, there's not a lot of time to get that ready.
Yeah, and of course, they say to prioritize action in the areas where risk, volume, incidence, prevalence, or severity are high. You want to start with those really important areas. Select quality improvement activities with potential for positive impact on patient safety or your quality of care.
Moving on to infection prevention and control, not a surprise that this is one of those areas. Again, 38% of the centers had citations in this area. And examples of surveyor findings included the organization's hand hygiene policy states that staff are to perform hand hygiene before and after patient contact, and upon observation, this was not being done. And also, rust was noted on the casters of a rolling stand that holds surgical suction canisters. I don't know why that was specifically brought out. Though I will state that I've seen that more than once in my time, and it's certainly not a good situation when you see rust on anything, any equipment in your organization.
Yeah. And actually, in their overall summary, they did say that the program, although it's documented and there's a lot of written documentation, that they evaluate through direct observation and through interviews with the staff, and that the overwhelming majority of deficiencies were breaches in hand hygiene. So even though those specific examples don't reflect that, it sounds like that was
hand hygiene was a big issue. Yeah. They also noted that, so this was interesting. It noted specifically that C-arm equipment was cleaned by a radiology technician and materials manager in the operating room before the procedure ended. I just want to tack on to that I've seen that quite a bit lately too, where the staff in the operating room have not waited for the patient to leave the room before they start cleaning it for the next patient. So something you need to make sure that you're doing. And they had a number of tips for compliance. Review the infection prevention and control program against the nationally recognized guidelines selected to ensure alignment. Include infection prevention and control as an element of regular staff training. Of course, that big trend here. Monitor the hand hygiene compliance, of course, doing surveillance activities, and conduct regular infection control surveillance rounds for equipment and environmental issues like rust, surface flaws, like divots, chips, and separations in your flooring and walls, and dust accumulation to promote a culture of cleanliness. And that leads us into the next area, sanitary environment. And 50% of centers had issues in this area. And examples, and again, I see this, unfortunately, quite a bit also. Gaps were visible in the seams of the floor. Biohazardous waste containers were uncovered in the biohazard room. Dirty linen from the prior day remained in the pre-op area a day later in an uncovered linen hamper. That seems very specific. Residual tape adhesive was noted on the OR table cushions and glass cabinet doors, and really tape should not be used in any of the areas because, of course, that's a dust collector, and it makes it very difficult to clean.
Any kind of tape or rust, all that stuff that just makes it difficult to do a good cleaning is important. And they say no evidence of pest or rodent control services. And honestly, I didn't know do they have to see evidence of a problem before they're worried about that, or does everybody need to have some type of a contract?
Yeah, because it's pretty universal that you're going to have some type of pest control issue. It depends upon the area. I've been in areas where spiders, your favorite insect, of course, sarcasm. That's prevalent in a number of different areas. Around here, I think it's stink bugs, given their prevalence, and flies. And then, of course, the bigger rodents like mice and rats. Of course, often this time of year, they're seeking warmer places. So you need to have an agreement, even if it's just for them to come on an as-needed basis. I've noted a number of times recently where we've had to bring these pest control organizations in because of a bed bug infestation. So that's something to keep an eye out. And they also noted that, again, that the integrity of the procedure room floor and door was not maintained. You need to make sure that you're doing regular observation surveillance of all of the areas for any perforations or punctures, and of course making sure your doors are properly maintained.
And then your favorite, right?
Corrugated boxes. Yeah, corrugated boxes are stored with clean supplies. Again, corrugated boxes, for those that are not aware, present an insect problem. So you might do a great job of keeping the insects away or scooting them away, but boxes that come in could have larvae inside of those corrugated boxes, and that's pretty common actually.
And you just can't clean them. I saw, and I think it was actually in a pharmacy consultant's report I saw once where they were talking about, not having cardboard, I guess it was in the operating room, and, because you can get blood, you can get anything on there, and you can't clean it
It's not cleanable, right. And they gave some tips for compliance, train staff, of course, on the policies, create infection control quality goals related to the environmental conditions, and, of course, conduct regular infection control surveillance rounds for your equipment, et cetera.
And lastly, medical records. 54% of the centers were cited for something in this, and some of the examples were records lacking documentation of the name of the healthcare provider or group responsible for administering anesthesia on the informed consent.
And we're talking, and again, this is universal, that you actually have to name the anesthesia provider, not the name of the group. So the specific name of the individual providing anesthesia. And by the way, we just had a conversation today, a center that did not have a separate anesthesia consent, and yet it was a separate anesthesia provider. So, of course, you really need to have a separate anesthesia consent nowadays.
And the informed consent is not completed by the performing practitioner. The physician only signs the document. The nurse fills in the procedure name and obtains the patient's signature. This is inconsistent with ASC policy.
So this is extremely important, and I really get upset whenever I see this. When I walk into a place and the nurse or sometimes even the receptionist asks the patient to sign the consents before the provider even sees the patient, and this especially happens with anesthesia. So the consent can only be signed after the patient has received informed consent
and the nurse
from
is
that provider.
Only verifying that the patient has spoken to the provider and has no further questions. If they do, you have to.
That's right. It's all right for the nurse to ask the patient for the signature, but only after that conversation, after that informed consent had been obtained. They also noted examples where records lacked evidence that the patient received the notice of the patient rights or the advanced directives, that there was incomplete pre-op nursing assessments, that the date and time of the history and physical was not noted, that the time noted on the time out space was missing. The time was missing on the timeout section of the surgical form. The RN and the patient's signature was missing on the discharge instructions. This one I found interesting, that a full operative report detailing the findings and techniques of the operation and the pathologist report on all tissues removed during the surgery was missing or was incomplete, which I got to admit, I don't know that that's generally a problem that I've seen in the past. So I was surprised to see that on the list. And the last item that they cited was kind of interesting, verbal explanation of patients' rights and advanced directives being observed during the registration or check-in process. However, there was no documentation that they were provided to patients in the reviewed records. So often I think what they're referring to is that there might be a checkbox saying that the patient was given verbal notice and that yet there was no indication that that actually occurred. So definitely important to make sure that's done. Now, I sometimes get questions about what they mean by a verbal explanation of the patient rights. And unless the patient doesn't speak the same language that the form is prepared in, we're not expecting you to read the patient rights and responsibilities to the patient, but we are expecting you to ask the patient whether they have any questions about it. Now, again, if the patient does not speak the language that you've presented the patient rights and responsibilities in, then an interpreter will have to read that document to the patient.
And so some of the tips for compliance: establish a baseline checklist for the minimum required documentation in the medical records. Educate your staff on the importance of writing legibly. If you can't read correctly, then obviously the documentation is not very valuable because you can't exactly tell what they're trying to say. Conduct random file audits and implement a verification and record-keeping process to ensure that verbal explanations of patient rights and advanced directives are properly documented on the patient's medical records. So this helps to bridge the gap between the verbal communication and the record documentation.
So we hope this has been useful for you in preparation for your surveys, if you're lucky enough to have a survey coming up this year. And with that, let's take a short break, and when we come back, we'll talk about upcoming events.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So the big event of the year, ASCA 2024, is coming up in Orlando, Florida at the Gaylord Palms Resort and Convention Center. It's going to be April 17th through the 20th, 2024. We're going to be there doing podcasts. I have 2 speeches I'm doing, as well as moderating a session. And we'll probably try to do 2 or 3 live, meaning that we'll record them live sessions. And by the way, if you are planning on going, try to meet up with us, send us an email, and we'll set you up on our little text system that we have for telling you where we're going to be at what time. And we love having our listeners join us for these podcasts.
And the Georgia Society of ASCs in South Carolina's ASC Association's joint semi-annual conference and trade show is February 22nd and 23rd, 2024 in Atlanta, Georgia at the Westin Atlanta Perimeter North, and on August 15th and 16th in Hilton Head, South Carolina at the Marriott Hilton Head Resort and Spa.
And Sue, we know where that resort is because we go down to Hilton Head. We're actually heading down there in a couple weeks, but don't worry, you won't miss an episode. I'm sure we'll be recording from down there. And Louisiana Ambulatory Surgery Center Association's annual meeting is February 23rd in Baton Rouge, Louisiana at the West Baton Rouge Conference Center.
The Gulf States Conference is June 11th through the 13th, 2024 in Biloxi, Mississippi at the Beau Rivage Resort and Casino.
The Arizona Ambulatory Surgery Center Association Conference is April 27th and 28th in Scottsdale, Arizona at the Westin Kierland Resort.
The Florida Society of Ambulatory Surgical Centers Quality and Risk Management Conference is April 4th and 5th in Daytona Beach, Florida at the Hilton Oceanfront Resort. And their annual conference and trade show is July 17th through the 19th in Orlando, Florida at the Signia by Hilton Orlando Bonnet Creek.
And our friends over at Becker's ASC are going to be doing the Becker's Spine, Orthopedic, and Pain Management-Driven ASC Conference. That's going to be June 19th through the 22nd in Chicago at the Swiss Hotel.
The Texas Ambulatory Surgery Centers Society's annual conference is June 24th through the 26th in Galveston, Texas at the San Luis Resort Spa and Conference Center.
And we're hoping to get out to California this year. We had to skip it this last year because of some other conflicts, but the California Ambulatory Surgery Association's annual conference is September 4th through the 6th in Anaheim, California at the Anaheim Marriott.
The Tennessee Ambulatory Surgery Center Association's conference is September 12th and 13th in Chattanooga, Tennessee at the Chattanoogan.
And in the fall, Becker's ASC is going to be doing their 30th annual meeting. That's a big one, 30th annual meeting. It's going to be the Business and Operations of ASC's conference, and it's October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency. And don't forget about our upcoming boot camps. The Administrator Boot Camp is now available to register, and that'll be January 23rd through the 26th, 2024. And our second ever Business Office Manager Boot Camp will be March 12th through the 15th, 2024. And more information about that is available on ASC-Central.com. On-demand versions of the ASC Director of Nursing, the ASC Administrators, and the ASC Business Office Managers Boot Camps are also available on ASC-Central.com. And also, you might be interested in our June 2023 on-demand version of the Multi-State Conference, which is eligible for 16 AEUs and 4 IPCH credits. It's a great conference, 2-day conference that was presented virtually, and includes a lot of great presentations, including presentations on infection control, life safety, survey preparation, human resources. We provided an introduction to the Medicare ASC payment system, discussion of pharmacy, and staff retention. And please also consider becoming a patron member of the podcast. The patron member program is an exclusive membership website at ASC-Central.com that provides a one-stop ASC regulatory and accreditation compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And resources include free access to various virtual conferences, links to resources for ASCs, policies and procedure forms, and fire and disaster drills. And, of course, our now famous weekly drop-in sessions, usually on Saturday mornings at 10 a.m. We have an hour where all of our patron members can get together and talk about things that are going on in their ASCs and, of course, ask questions. And we usually have 2 surveyors on that weekly call, and sometimes 3 if we have our life safety surveyor available. Membership in our program helps defray the cost of producing the podcast, including research staff, travel cost, conferences, equipment costs, and production costs, and more. And for more information, visit us at ASC-Central.com. And membership is only $25 a month, which is a real bargain for that type of access and the ability to ask questions of surveyors in a very relaxed environment. And we really do enjoy our Saturday morning sessions. We have a great crowd. So thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found this episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so that you never miss an episode. We'd love any feedback about our episode or ideas for future episodes. Indeed, we get a lot of the ideas for episodes from our listeners. And to do that, send us an email at comments@ascpodcast.com. We'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Caloritis, Jim Masters, Amy Cronkite, Lori Rodricks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. We couldn't do it without them. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms or at our website at ascpodcast.com. Thanks for listening. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.